Really excited about our final panel today. Those of you who have hung in there and stayed with us, I think are in for a real treat. This panel is on innovation and care delivery and payment. We're going to be talking about a lot of the themes we've been developing throughout the day, and I think you're going to be pleasantly surprised to hear some of the wonderful things going on in Missouri. We have 4 panelists this afternoon. We have Dr. Joe Boyce from Heartland Health. We have Mary Castle, who's the new president and CEO of the Missouri Health Connection. We have Dr. Tom Hale, who's at Mercy Center for Innovative Care, and Dr. Summer Musafir, who's a medical director at MoHealthNet. So Dr. Musafir is going to talk about the patient-centered health home efforts. Mary's going to talk about the Health Information Exchange, what's happening in Missouri, and Tom and Joe are going to really give you examples of what some of the most innovative systems are doing in our state. So without further ado, Dr. Joe Boyce.
Thank you. Good afternoon, hardcores. It's Friday afternoon. Good news is I've got a lot of material to go through, but Joe Flower just covered a ton of it, so I think I'm going to be able to go right through these slides. They say you always remember 3 things out of a talk. I think the very first thing is if you're not confused, you don't know what's going on. There's just so much going on right now. The incentive, if we get the incentives aligned, I think the rest of this stuff will come around. The incentives are the key, and right now they are perverse and adversarial. What I'm going to show you is how some of the technology is actually applying some of those things that Joe talked about. He talked about all these things. Let me tell you a little bit about Heartland first, 300-bed hospital, small community hospital in St. Joe, Missouri, just north of Kansas City. We do have several ACOs. We've got our own ACO with our own caregivers. We've got a Medicare ACO for just since July, and we have commercial ACOs with Aetna as well. And I can tell you that in the last 6 months of ACOs, I've seen more change than I saw in the 20 years beforehand in terms of new processes, new change, things like that. So it does work. We're going to talk about how some of those things work. I'm just going to talk about the differences between, or the accent, some of the things. You heard about 5%, 50% spending on 5% of patients. It's absolutely true. A lot of that is at the end of life and the beginning of life in NICUs and ICUs. And so you start looking at process measures like chemotherapy in the last 2 weeks of life. Crazy quality measures. They're not on the ACO scorecards. They're not in other places. If you start looking at those things and saying, why are places doing this? What's our percentage of that? That's where it's going to come in. Now, I want to accent one of the dangers of an ACO. If before we were making money off of doing things, in the ACO, if you're making money off of not doing things, you better have pretty clear and explicit criteria about why you're not doing things, or guess what the first thing they're going to say about this is? Death panels. That's exactly right. Yeah, they're going to say, you guys are making money off not giving my mom that treatment, and even if you're treating a daughter who hasn't seen that parent in 5 years, all of a sudden you've got to treat that family, you've got to do everything. If you don't have explicit criteria already published, that is the real danger that we're seeing. So we've seen a lot of programs that have come in, a lot of places grouse about this, a lot of physicians, are upset. You're forcing me to do this, but it's just stuff we should have been doing anyway. It's very simple, straightforward stuff. Same thing for the ACO. What is an ACO? It's a defined team of caregivers. We heard all of this from Joe. Care plans. It's stuff we should be doing anyway. It's your record. You shouldn't have to be asking, for permission to see your record. At Heartland, we turned on, Cerner's version is called IQ Health. You can see your own notes. You can see your own labs. We thought it would be a big hullabaloo. It was nothing in terms of turning it on. Patients like it. We can't get patients using it enough. How do you engage those folks? That 5% of patients that are costing 50% in our population, huge self-pay, I got news for you. It's not the folks in this room. It's the guy buying an 18-pack a day, going to look for a hit of meth. Those are the folks that are costing us a ton of money in the ED and everywhere else. Those are the folks, how do we change those behaviors? They're extremely difficult to engage. And so we've got a lot of outreach things. And then getting the docs to care. I think the question right before the end of it was, how do you get docs to want to change? How do you incentivize them? Well, if you're making $600,000 a year as an orthopod or a cardiologist, you're going to have to argue them down to $400,000 a year. That sounds like a pretty good salary to most folks. But you've got to explain to them that this is the path we're going. I don't know if the path we're going is from left to right, from fee-for-service, maybe not to capitation. I'm very interested in what you were saying earlier about a capitated rate or a direct primary care payment, because I think that's a very exciting notion, because you can have the controls right there at the local level where you can actually know who's really still smoking and who's doing what. I think that's very exciting. But shared savings, where we're at in that second from the right there at the end with an ACO, all of a sudden, all you're doing is still measuring by fee-for-service, but you're sharing by the overall outcomes. And so you've got to have adequate populations. We've only got about 10,000 patients in our Medicare population. The problem with that is you get one or two bad cases, you can blow up your numbers very quickly. You need about 100,000 patients in any insurance pool to really smooth out the bumps. The other problem with the Medicare ACO, we're pretty excited about our commercial ACOs, but the Medicare ACOs, patients can go anywhere they want. They have no skin in the game in terms, other than their health, in terms of where they go. So if they go down to Kansas City and get another MRI for their back because we refuse to give it to them, even though we're following the exact protocol we should have been, it's going to cost us money. And so that's a big flaw in the Medicare ACO problem. The good news is still, so we saw 20% reductions in costs for the first year of our own caregivers with an ACO. That's pretty significant. But all these other things, value-based purchasing, readmit policies, bundle payments, guys, it's too complex for any small physician group to understand this stuff. There's no way. You've got to have adequate size. You've got to have the scalability, the pools of smart folks that can understand these things, and then pop up alerts at the right point to show it to folks. I agree with everything they said about measurements. It's about population management. I'm going to jump through these things so I can show you some of the ways we're actually getting it in front of docs and caregivers at the point of care. Again, you heard about that. I want to accent one thing on the second point there. Data warehouses are key, but interfaces are what are killing us. If it's $40,000 an interface to get a problem list out of your system into mine, they aren't going to happen. The HIEs, I know Mary's going to talk about it. I mean, we're talking about how do we get our HIEs to talk to each other? Okay, is it going to be a CCD? Is it going to be HL7? What are the 5 things that we're going to do? That's where the money is. That's where we're going to have a great difficulty in terms of finding efficiencies in care. Again, the computer systems, if you give me 5 things, problems, meds, labs, allergies, orders, notes would be a 6th one I'd love to have, but if you give me those 5, the computer can understand the context, we can start popping alerts at the right time at the point of care before you order the CT scan and save money. Hey, this guy just had one 2 weeks ago, did you know that? If I can't even get my ED docs to read the chart when I'm putting all the data I'm going to show you in front of them, I got to pop an alert at the right time. And they may beef about, hey, you're interfering with my workflow. Yeah, I am. You're right. It's a bad workflow. The right data, right place, right person, right time. There is an art to alerts that's really tough. Now, Heartland's what we call HIMSS level 6. There's 7 levels. Doesn't really matter. We've got all the tools we need. We are ahead of technology. It's the first time I've ever said this in my life. We're ahead in technology in terms of the talent to deploy the tools. Okay? We don't have the processes in place for every nurse at every place to document things the same way every time. We've got inpatient CPOE and documentation and barcode meds administration, and every one of these has had a stair step in terms of the quality outcomes and measurements. Every one of them is working. Patient entered data, I would love to have patients entering data right straight into the PHR with some validation and some quality measures and control. I think that would be a wonderful step. We're not quite ready for it, just human process-wise. I can tell you the ACO and everything really changed it. But what I get asked when I'm starting to look at these programs is, where's the ROI? We're getting 1% cut here, 2% cuts there. Where's the ROI in terms of a return on investment for that specific project to turn on that notes for the patient? I found it fascinating listening to Joe's talk about how for these different areas of the old way we're doing things, how inefficient it is, and then we start looking at the new ways. Again, team-based medicine. The only thing I would add to his team is the patient's one of those members of the team, and the computer's one of the members of the team. Those are key members. And to be honest with you, if we did this really right, the patient's doing it from home. They're only calling us when the web doesn't understand the context. You got Isabel, you've got all these different systems. We're talking to Isabel folks. Let me open that up for patients, up to date. Let me open that up for patients. You type it in. I love it when patients come in with a stack. 20 years ago, the first patient that came in with a stack of stuff, it was kind of daunting, and I discovered I love that when they're thinking about what's going on already, and you got to ask that question, what do you think it is? Because half the time you're treating what it might be that they're worried about their sister, that kind of thing. But mobile, team-based, we're doing so much work with home health, discharging patients early for heart failure, and then having a nurse go to the house, manage the IV, manage things right there in home. I don't know about you, but when I'm sick, I'd much rather be home with my dog than listening to the buzzers and the beepers in the ICU or in the hospital. So it's really fascinating how we have all that. So given all that, a lot of folks focus on the EMR as the dashboard. It has come a long way from the 60s. Then you've got, and I use a military analogy because I think it really is the same level of revolution. We've got into modern displays, a lot of information. But all of a sudden, there's a whole revolution in the way we change things. Well, now we have the information in healthcare to go beyond just implementation, getting docs to use the CPOE, getting docs to document online. We're actually extracting that data and getting actionable information at the point of care that makes a big difference. That's pretty exciting. And I apologize how washed out this is. It's a Cerner product again. It's called, the M-Page is kind of a cornerstone. The key of this is that we can customize this screen and the doc can make it look like anything they want, because the one thing you guarantee is you can't make something that pleases everybody. So you can move things around on the screen. You can say, I want to see pathology reports right here in the middle, or don't, whatever they want. They can change it around. But right here in the middle, the console is what things need to be done for this patient as an individual in terms of, mammos or colonoscopies or any of the, if we know they've got certain problems, then we've got actionable problem quality measures that says this patient hadn't had an A1C or hadn't had a foot exam, hadn't had an eye exam in the last year. Those kind of things on the individual patient are great. So the doc knows what they're supposed to do, or the nurse practitioner. Good chunk, about a third of our primary care folks are nurse practitioners. That's coming more and more, guys. That is, they're going to be driving a lot of the boat. But those folks are seeing it right there at the point of care about what the recommendations are for that patient. So you can see what needs to be done. If you click on show all, you can see, okay, show me all the measures that have been done for this patient that actually were done. So half the time it's, I did that at some other doctor's office. Let me take care of those measures right there at the point of care and document exactly what happened and put down the exclusion factors. I'm not going to do that, doc. I'd rather not take that med. The patient should be driving that, but the doc shouldn't be penalized for those exclusion measures. And the exclusion measures are the hardest things to manage. It's not just getting the quality measures themselves met. But then also show me what the evidence is at the point of care, so you can show the patient. Look, it says right here, first episode of back pain with no flags, you're not getting an MRI. I'm not just a bad guy that's making money off of you. And I think that's really key. We don't have good enough evidence in a lot of places. I mean, showing patients up to date, things like that helps, but sometimes it is a probability call in that whole conversation. The other piece, how we've incentivized docs, is they're very competitive. They don't like graduating towards the bottom of the class when we show it publicly. So these are our docs, real measures. Here's their A1Cs over there in the top, and if you click on that not done measure, it's going to give you a list of patients that have not had their A1Cs. So somebody in the office, either a care manager or the clinic manager, can call those patients, and these instantly, as soon as you start showing docs numbers like this, they start creeping to the right, because the competitive ones start shaming everybody else, and we're showing them publicly. And you didn't have to pay them a dime. You didn't have to do anything differently other than start showing the measures. And I think that makes a huge difference as well. The other piece of it is, how do I pull in data from outside the systems? This is LACI. It's the Health Information Exchange that Heartland has built. I think the one key thing we found is that as we opened up clinics in the Kansas City area, everybody's going, wait a minute, you're being competitive with us now. We're worried about your HIE. You're just going to be pulling our data in. $2 million investment, we're going to give it away. We're going to donate it to a collaborative. I called up all the competing hospital systems in the Kansas City area. We had a little CMIO dinner. Said, look, if this thing's not going to grow if Heartland owns it, would you like to run it? Would you guys like to? I mean, it's $2 million, and if it's either not going to succeed, either go big or go home, is the notion of this thing. So I'd like to turn over the board chairmanship of LACI to the folks at KU or Children's or Truman. I mean, those folks are in the middle of the Kansas City area. That's the folks that need to see the report data down there and see the actual notes and see the information of the patients. But again, if it's $40,000 in interface, that's where we're gonna struggle for every one of those folks to get plugged in. So we've got to have those grants and that support to integrate it, and you got to look at where your referral pool is as well. But the other big point of this is it's within the EMR, and you don't have to log in again. I think that's a really key aspect as well. Something a lot of folks don't appreciate too with an HIE. Where did that information come from? If you've got 5 problem lists coming from 5 sites, you've got 5 diabetes. And how do we ever get to consolidation and contraction of that record to where there's one of those showing? Nobody's ever touched that in the world to my knowledge. The other big piece is decision support at the point of care. Since you know that what the patient has in-house, you can start those timers when they first got admitted. This is an inpatient VTE alert. Let them take actions right there at the point of care. Docs love this one down here at the bottom where they can reassign it to somebody else. But it's a team-based practice. You've got hospitalists, you've got different folks coming in. I may be the cardiologist, I'm not taking care of that. The surgeon's going to take care of that. Show them why with the risk calculations, give them actionable orders, let them document the exclusions as well. And then once they've made an order, in this case they've ordered an anticoagulant, give me the associated labs that are supposed to go with that as well. And let them order things right there, not jump out to some other place and do some other orders somewhere else. Lastly, just looking at the population summaries. Okay, so you've got all this data on the individual patient. How do you start managing a population as well? How do you see, and I've got the names grayed out here or fuzzed out, but How do you see for, in this case, I'm looking at all the quality measures for Dr. Rippey. This is for our Medicare ACO within the next 2 weeks, patients that are coming in, so you can make sure things are going to happen before they come in for the office. You didn't waste the office visit. What are their quality measures for diabetes? What are they missing on? You can sort on the columns on this thing. So all of a sudden the care managers are proactively calling patients and saying, let's go ahead and get that test 2 days beforehand so the doc can talk to you about it when you get here. And that makes a huge difference in terms of just having other touch points for the patients and just calling the patients and having, again, that team-based management as Joe mentioned. And lastly, just who's at risk? Who's using most of the resources? With Heartland, it's about 2/3 Medicare, Medicaid, about 8% self-pay. Those are huge numbers. Those are not a commercial population. That's not Columbia. I mean, we would love to have the commercial payers to cover everything else. But for us, it's who's utilizing the most cases, who's touching the system inordinately, and can we take better care of them? Can we start managing that better? And so I'm sorry you can't see the list here, but it's how many ER visits they had in the last 3 months, how many ER visits in the last 6 months, how many care management visits that they had, how many primary care visits, and you can see the notes with the touch, and you can start looking at the population. We never had these views before, and all of a sudden people are looking at the tool going, how do we want to manage this? Who's the right person to call somebody about their diabetes? Is it a diabetes educator? Is it the doc? Is it the nurse? Is it talking to the daughter? And where do we record all that so we don't have that same conversation again next week? Those processes are what are, all of a sudden the tools have opened up all kinds of discussions we could never have before. It's very exciting. So I think this is what everybody's been saying. Why are we doing this? I can tell you that one of the biggest issues for us is the burn rate. And I think Joe talked about it, Dr. Sun talked about it as well. How fast do we want to cut our own throat? In the fee-for-service world, with an ACO, we are competing with ourselves. We're stopping doing procedures on the inpatient side. We stop admitting patients and put them in the OBS unit instead. We hurt ourselves. We know that it's going to be about a 2 or 3 year drop. We're not going to make money on some aspects in order to be a survivor at the end of it. But if you don't do that at the end of it, with all those Medicare, Medicaid cuts coming, it's going to be a very dangerous world. I've heard numbers of 1/3 of hospitals closing. All the critical access hospitals around us are calling us going, what are we going to do? They've all got negative cash flow. It's going to be a very tough world. If we feel like this is a survival rate. This is if you don't do this, you're going to have a hard time. But the good news is, instead of having some event when you're 50s and having your heart attack in the 50s and having this not wonderful life, if we do all these things and have the healthcare promotion, the CFOs love it because it's lost productivity, fewer claims, you have that compressed morbidity at the end. 2 weeks of illness when you're 80 years old and have had led an active life, that's a win-win all the way across the board versus this slow decrement over a long period of time. So this argument, or this process is actually working. The problem is it takes a long time. And if we're looking at something that's going to take 10 or 15 years to pay off, you've got to have large enough systems, you've got to have stable enough systems, and you've got to stick to it for the long-term investment. So I hope that explains kind of where we're going and how we're going about it. I think we're going to take questions at the end. Is that right? Okay, great.
Well, I was supposed to be in Bermuda this week, so I don't have any slides. So I'm going to talk to you a little bit about what is the Missouri Health Connection and some of the philosophies that we're going to be using as we work together with folks from Lacey and Tiger and all other healthcare systems across the state. I've worked in healthcare since the ancient days of the dinosaurs, and I think that really the revolution of my time is not in technology, it's in the use of technology. And I think that the things that Dr. Boyce just shared with you demonstrate that the use of technology is really what is the key. It's not that we have the technology, it's how we utilize it. And I think most importantly, I share an optimism with a lot of the speakers today. I think that the natural use of that technology is only on the upswing. As my children start to enter the healthcare system, all of the things that we've, over the last 30 years, had to train become intuitive to them. So I think that is something that we really need to consider and take a little bit of thought to. The education budgets that we had to use in the past to implement technology use really should diminish because the technologies that we're using are more intuitive to the younger populations as they enter the workforce and they become the consumers of healthcare. So I think that's one trend that I think we should all keep in mind. The other thing that I really found interesting in Joe's presentation on before us is the value of team. That is one of the most fortunate things in my career. I had the opportunity to be a CIO in an organization before the days when we all had glowing values and mission statements that were, very, very lofty. And we had one core value, and that was teamwork. And this is in the 80s, and we, at that point in time, had multidisciplinary teams on every single project in the organization. And the dynamic change that was able to bring about through all the perspectives that were brought to the table in implementation of IT, I saw the power of that teamwork. And I think that as Missouri works together as a team across all of the different constituencies in the healthcare marketplace, I think we need to remember that that is most important, fundamental. Another thing that I wanted to talk about today is I just want to point out a trend that I think we all also need to be aware of. In my early days in healthcare IT, the IT budget in a hospital used to be under 2%, if it was even close to that. And over the last 10 years, we've seen hospital organizations primarily shifting that budget away from, they used to put into medical devices or medical equipment, large medical things like CAT scan, MRI, building new buildings, to a large investment in systems for their organizations. And when you think about a Providence Health System in the West Coast that is investing $1 billion in IT, and compare and contrast that to the infrastructure dollars that we have now to build common systems across our organizations, I think we have some adjustments to do in how we think about this. And I think it's a value to realize that we can't, as an industry, keep spending that kind of money to implement IT systems in organizations. We have to look at some of those more fundamental things around teamwork, around the fact that things are more intuitive now, and become very much more aware of the cost to implement a system within an organization if we hope to have any money left to do things across states and across our country. I think that's extremely important. I think that also really what we need to do is start with very simple things first instead of more complex. The presentation that Dr. Boyce just gave went into a lot of details that we have barely touched the surface on, as you mentioned, with integration. It's extremely complex. All of the data sets that are in every organization, even if they have the same vendor, every single one of them looks different. And so we're going to have to, as a group, work together to simplify what we start with so that we have a firm foundation, and then we take steps from there to build integration across our systems. My life has been spent in hospitals and in all of the acronyms of Health Information Exchange, what's now known as HIE. It started out as Community Health Information Networks, then they became RIOs, then I think there was another acronym that I've probably forgotten, and now Health Information Organizations or Health Information Exchanges. It's really about transforming our care so that it's not in the silos of different hospitals or clinics, but that information is available to all providers across a large area. Wherever the patient may go, that information needs to be available to the physicians and the caregivers so that they can take care of those patients effectively and efficiently. And I think that my last principle is I'm a child of the 60s, so I believe in power to the people. I believe that in delivering tools to our patients, we can bring them closer to improving the care and working together with them in every facet of how we do this, both in their opinions about how we maintain their data, how we capture their data, how we share their data, and then also in giving them back the control of their health care by giving them reports that they can read and understand. I think is an extremely important principle for Missouri, and I'm very happy to have joined an organization that has spent a lot of time on the consumer and the patient side of this, because I think that focus is fundamental. So again, no slides, but those are some of the principles that Missouri Health Connection is using as we now start the work. So excited to be back in Missouri, and we'll look forward to working with all of you.
It was nice to hear somebody talk about being a child of the 60s. I just barely made it out of the 60s. And actually, as I was listening to Andrea talk about her experience of seeing someone in a role she was in a long time ago, and a long time ago to Andrea was in the 1980s, I had to think to myself, well, when was my first experience when I really interacted here in Columbia, because I'm a longtime St. Louisan. And it was actually when I was playing basketball for Iowa State, and we played Missouri in Brewer Fieldhouse, and it was Norm Stewart's first year coaching. So if I actually have a stroke up here, I assume that one of the doctors will take care of me. Listening to Joe Flowers talk was like an epiphany to me, because I came to the realization, because 3 years ago, our CEO, Lynn Britton, and everything starts with good leadership, and Lynn is one of the best I've been around. And I realized that he must have read Joe Flowers' book, because that is our strategic plan. And if you sum it up, it's summed up into two things. One is we will no longer feed the beast if we build another hospital, except for those that are destroyed by Cat 5 tornadoes. But if we build another hospital again, we will have failed. Our long-term strategy is to grow the village. The 5 things that Joe brought up, 4 of them we are doing because of the other one we can't do anything about, and that's payment methodology, the change in payment methodology. But our CEO said, I want you to go do these things regardless of what our payment methodology is, and regardless of whether you get paid for it or not, we want to do the right thing. And that's to grow the primary care, to use that crew that we talked about, or that Joe talked about, swarm the customer, and change processes. So I'm in charge of the Center for Innovative Care, which is where our Lynn asked us to develop the new care model, as he put it, which I think Joe kind of laid out all the strategies as to what that would be. And so today, understand that there is several things to the Center for Innovative Care. Process is one, and that's making the patient-centered medical home and the coordinated care and care management. And then there's technology, and today, in the limited time I have, I'll deal mostly with the technology piece, but understand we're not doing technology to ignore the care delivery portion, because at the heart of what we do is the relationship between the caregiver and the patient. So anything that we do from a technological standpoint, if it interferes with that relationship, then we don't do it. Interestingly, we find that most patients are actually very comfortable with telemedicine. In fact, more comfortable than most physicians are. Which reminds me, when we did the EHR first implementation, and I was actually still in practice at that time, I was such a technocrat that I took the chart with me in there with the computer, just in case it would fail. So what you're seeing there is a rendition, actually an artist rendition of our Center for Innovative Care, which we're building in Chesterfield. Out of that, we'll coordinate a lot of the things we're doing today, but also represent a place where we can have a think tank, so to speak, of new innovative things in the future. Just to give you an idea who Mercy is, because depending on where you're from, some people from Springfield, some people from St. Louis, think of that as that hospital there. We actually go from St. Louis all the way down to just north of the Texas border. I used to call them the Route 66 Sisters, and they ran out of nuns at Oklahoma City from St. Louis. We're about 31 hospitals at the present time. We do believe in integration, not ownership of physicians, not hospitals owning physicians, but a partnership, and it is a true partnership, separate actual corporations where the physicians do lead themselves, and work in partnership with the administrative portion of the organization. We have about 1,700 integrated physicians at the present time, heavily weighted to primary care, and we actually have 600 advanced practitioners, and I fully expect that at some point in time in the near future, our advanced practitioners will probably double our primary care physicians. Why are we doing this? All the things that were already said today. So essentially, it does, in my opinion, boil down to two things, though. One is access to care, and the other is care coordination. And if we succeed in doing that better, then we think we can lower costs. We think we can provide more efficient, effective care, and certainly make it patient-centered. So just to give you at a high level, this is my life as what the Center for Innovative Care has evolved into. We have a research arm on one side, which does a lot of patient effectiveness research and looks at things like predictive modeling through the data, utilizing big data, things like that. In the middle is the care delivery, the people end of things, the case and care management. And then on this side is the telemedicine portion, which I'll talk a little bit in more extensive today. So from telemedicine, we look at telemedicine as being four different aspects, okay? We look at asynchronous care, which is nurse on call, asynchronous care, which is e-visits, e-medicine. We have a PHR, which we have 250,000 patients that utilize today that does e-visits. They make their own appointments, they ask for refills, referrals, get a great deal of patient information, and that continues to grow. Next is store and forward. That's a classic, been around forever. In fact, dermatology is a big store and forward area where you take a picture or an image and then you store it and forward it to someone at a distant place to review and give their diagnoses. Decentralized consultation, that's the bringing a specialist from St. Louis to talk to a patient in Joplin or from Oklahoma City to talk to a patient in Arkansas. I saw that there were some representatives from TIPS here. You'd be happy to know that one of our first decentralized consultation was actually pediatric neurology to deal with ADD, ADHD, and also child psychiatry, and widely accepted and by the patients. And in fact, it gets many accolades. And then finally, a centralized hub model. This is our EICU, where we monitor all of our ICU beds, 450 of them, throughout the organization from one hub. This would also be monitoring that one does with home monitoring to screen through that. To the gerontologists over here, it would be, I used to call it SNFIS. We now call them community hospitalists, which is much better than SNFIS because it doesn't sound like I'm an allergist. But to monitor the skilled nursing facility patients so that they don't get sent to the emergency room. And behind that telemedicine core infrastructure, you have to build distributed scheduling, credentialing, try to credential physicians in 4 states. It's been a real challenge going across the board. So this speaks a little bit to what Joe was talking about. These are the things that we put in place in a patient-centered medical home. We have 100 physicians who are NCQA Level 3 certified, and I would tell you we are not going to become certified anymore because it is much more process and paperwork than it was value. So we are now taking what we consider the value out of the patient-centered medical home and applying that rather than going for the accreditation. But we put all these things in place, and what we found out was that we did a study with Milliman on 1.5 million of our patients, and they told us that if by doing all this, we'll lower Medicare costs by 8.25% and commercial costs by 9.6%. Just to put this in perspective, if I put a medical home together with 2 nurse practitioners and all in, it's going to cost me $1 million to support that. If I tell a CFO that I'm going to do that, he faints. Wakes up crying, as Joe said, every 2 hours. However, the real PMPM cost of doing that, excluding the physicians and nurse practitioner salaries, just all the support that this all represents from a commercial standpoint is only $2.50 per member per month on a commercial life and only about $13 per member per month on a Medicare life. What's the advantage? What's the value proposition there from a revenue standpoint? In a Medicare world, decreasing 8.25%, you probably are availing yourself about $120 per member per month. So we got to start, as Joe Flowers had said, we got to start looking at the financing in a different fashion. I do want to say that one of the results we've already seen down in Springfield on readmission rates, we now have our congestive heart failure readmission rate now to 9.2%. We've actually been given the challenge by our CEO that all our major facilities get their readmission rates down below 10%, not below 20% or 15%, below 10%. This is what we do in a telemedicine aspect. All of those boxes represent a project at some point in time is in some stage of either development, implementation, has already been up and running. And it supports access, care coordination, and grows volume. So we're growing the village, we're not feeding the beast. So I want to talk about 3 of them today. Very briefly, but just to give you an idea of what the impact is of putting telemedicine and virtual medicine in place. Telesepsis, EICU, telestroke, and video remote interpretation. On the EICU, like I said, we monitor our beds 24/7 across the health system. The mortality rates have gone down 20% below the predictive as based on Apache scoring. 30% reduction in ICU length of stay, 50% decrease in central line bloodstream, and greater than 95% compliance with ventilator-assisted pneumonia bundle protocols. In telestroke, all of our major hospitals, the critical access hospitals not yet, but all the major hospitals in our health system now have a telestroke program in their emergency room. And I put trebled there because it would sound silly if I told you that in Hot Springs, in that particular emergency room, they gave TPA 7 times in 1 year, and once we put telestroke in, they gave TPA 45 times in less than 3 months. It's a significant impact to be able to bring a neurologist to the emergency room real time and to be available there. Knowing that the patient's coming in by the ambulance, the neurologist is already there for that consultation, and time is brain. In sepsis, this is something that we built off of our EICU. So we did, I won't go over all the details on the large study we did on sepsis, but we learned that when the heart rate goes up and the respiratory rate goes up, that patient is starting to go into sepsis if they go up at the same time. And if you intervene, you can arrest that development from going through a localized infection. Severe sepsis is overall inflammation throughout the body, and then organ failure and septic shock. And by using identification of people at risk and then running that through our hub of the EICU in one hospital, we decreased mortality by 50 to 60%. Compliance with sepsis bundles went up 30 to 40%. Length of stay went down an incredible amount from 8 days to 3 days. And over 9 months of the program, based on those reductions, we saved 100 lives in one hospital. And we haven't even made it all hospital-wide yet. This is a significant impact, obviously, but it is an impact that came out of work that we didn't even know we could do this. It was work of the EICU, which we then moved on into sepsis. Video remote interpretation, basically what that represents is that, and if you've ever been a physician in an office and someone comes in and they speak Chinese, the only way you can take care of them is basically becomes charades. Our veterinary medicine, you just start ordering tests until something comes out positive, or they all come out negative and you tell them they're okay. Video remote interpretation, which we are spreading throughout the health system, it is in Springfield at the present time, is that the physician or caregiver can press on a button on the language and a face comes up on the screen within less than 15 seconds and allows that interpretation to be there during the live environment. Then it also includes, by the way, signing. For those who are hearing impaired. These list all the differences on your right, my left, if I'm facing this way, of what happens in the cultural disparities secondary to language difficulties. And these are the differences on my right where it can make an impact. Just as an example, we put a nurse practitioner clinic in Roosevelt High School in St. Louis, associated with one of our medical homes. And interestingly, I had no idea, but in that particular high school, there were 21 languages spoken. In Missouri, there are greater than 100 languages spoken throughout Missouri as actually the population's primary language. So it is a need that makes a significant impact. And as an aside, on the nurse practitioner clinic that we put in the school in Roosevelt, the only people that complained about that were the other schools, because our football team at Roosevelt now got on the field much faster because they got their physical examinations by the nurse practitioners, and they said the other schools said there was an unfair advantage that because they had to wait as much as 60 days. So that's it. That's what we're doing from a high level on telemedicine. You saw all those boxes. There's a lot of story behind all of those. I showed you some of the high points. I think it is a way for us to be able to provide access and coordination of care and conserve our resources so that we can provide a much better care at a much lower cost. Thanks.
My question is for Summer. You spoke to this a little bit in that there was a requirement for interoperability, but can you speak a little more to the technology that supports the care coordination?
So there are a couple things going on. Each health home should have its own EMR, and so it's up to the health home what technology that they use. We don't require that they use any given product or vendor. So we lay out the basic principles of what they need to be doing, and then they operationalize it. So we haven't defined what they need to be using or technically how they do that. In terms of the measures that we're generating, there are specifications for the data that needs to flow to the central warehouse to generate those measures.
Other questions? There's a question here in the front and in the back.
I had a question for Tom Hale. If I remember correctly, I think you said that your CEO said, you know, we'll go ahead and move forward with the future of healthcare across Mercy, regardless of the payer incentives that might be available for you. That might be the only time that I've heard a hospital CEO not be concerned about the margins. So, is the board concerned about this? Somebody's got to be worried about the bottom line. How do you build support for this across the institution and say, well, we're not too worried about our margin?
Sure, and I didn't want to give the impression that he's blissfully traveling along and not worried about the dollars, because certainly everybody's concerned about that at some point in time. No margin, no mission. However, I think it is Len's feeling that as we develop this, as I said, we grow the village, and we know specifically that. In order to make that 8.25% decrease in utilization amounts to a 15% decrease in revenues to our hospitals, which is the beast that feeds our hospital system. It means that we need to grow our primary care base by 24%. So you can't take one aspect of this and say, okay, we don't get a payment methodology for EICU, but you can see the positive impact that it has both on utilization and quality. So therefore, there has to be a parallel strategy to grow the business from a volume standpoint so that we can survive the transition as we start to move into payment methodologies. Second point on that is that in actuality, when we enter the ACO world with our Springfield and Rolla physicians, we will have about, through all our various contractings and things, about 150,000 patients in a shared savings arrangement in some fashion or another. So we were already entering that way from a payment standpoint. What we didn't want to get into was how we, to not do a project because, say, in telestroke, how are we going to bill for that? Well, we can't do that until we figure that out. We're doing it in reverse. It's the right thing to do, and now how can we show that that has such a positive impact that we can develop a payment methodology around it? Remember, I said that we were worried about the money, so my board chair doesn't kick my rear end.
There was a question up here in the front.
Follow up with Dr. Samar. How did the Medicaid homes, health homes, recruit their patients?
So what we did essentially, once we identified the health homes, we ran our system to identify patients affiliated with those health homes, and then we ran those patients by criteria. So we started with the health homes that we had identified, and then identified patients seen in that group of health homes.
There's a question up here in the very front. She's had her hand up for a while.
And I actually have 3 questions, so I'll get them out. The first 2 are for Samar. I wonder, I work at Katy Trail Community Health in Sedalia, Missouri, and we're part of the Health Home Initiative. And I'm going to ask you publicly in front of everybody, when are we going to see cost data so that we can really evaluate ourselves in terms of how we're doing? That's my first question. My second question for you is about, I'm curious as to how, I know how a behavioral health consultant works in a primary care environment, but how does a primary care consultant work in a community mental health center environment? And then I have a question for any one of you, which is this whole ACO idea in a rural environment. I heard you say 100,000 lives. And I'm trying to figure out 100,000 lives with a half a dozen hospitals and you know, a couple of community mental health centers and are they there? Do we have models? Those are my questions.
So I guess with the first 2, for the cost information, that will take 12 to 16, 18 months probably to put together. So with the primary care side, we had a staggered implementation. So some health homes started in January, some started in February, some started in March, and some started in April. So, and then you have about 3 months or so for claims and things to catch up. I think you need a good year at least of data, and then you need time for those claims to catch up in the system. So we started looking at the evaluation plan and the methodology of how we will determine that. We did do, we had projections for cost savings when we started this, and that was part of putting this model forward. So we do have the projections and what we have modeled in terms of savings. But to see the actual savings, I think, is going to take a little time. We're just getting to a year of the program being up, and for those that started in April, you know, we're not quite at that year. But as soon as we have that information ready to share, we will share it. I know everybody's eager to have that. We'll share it as we have it. The second question, on the primary care consultant on the CMHC side, they make sure that that patient, one, is connected to primary care. They are not the health home, the primary care clinic for those patients, but they make sure the coordination of care is happening with their primary care providers, you know, making sure there aren't any gaps in that care. So they are a point of continuity between the primary care world and the CMHCs. And one of the tools, some of the tools that we've developed are, as you know, automated reports of when patients at least have been prior authorized for an inpatient stay, and making sure that care is being coordinated. Part of the concept of the medical home or the health home model is really that population management. So some of the reports that are being generated are really to run through the population of patients and then to flag patients that potentially fall below certain benchmarks so people can focus on those. And then some health homes have really use their electronic health records and their system to build ways to flag those patients. We go through a process where every month we have that attestation process, and we encourage everybody to touch every patient every month. So different, you know, health homes are doing a wide variety of things, and they're automating ways to look through their system on that population level again, to focus, to pull out patients that fall again below certain benchmarks or that are flagged for certain services and interventions.
So on the rural-urban place, Mercy takes care of about 3 million patients. 60% of our patients are in rural areas, so about 1.8 million patients. We actually find that the medical home and risk sharing actually works better in the rural areas than it does in the urban areas, particularly St. Louis, where there's a myriad of choices one can make as to where they decide to get their health care at the moment they decide they need health care. And that's less so in the rural area. But where we are finding some advantages to what we're building is that the telemedicine portion and bringing specialists to the critical access hospitals in the rural areas actually is much more advantageous even than it is in the urban centers.
Yeah, just add something. I mean, you can do it with smaller populations. Just you take more risk on yourself, and in a mixed environment where you've got multiple caregivers, and again, the Medicare one's different because they can go wherever they want. You can do either the no risk 50-50 split or 60-40 split with mild risk, but either way, the data's still out, whether it's, I mean, this is the only card the government has to play right now, though, to be honest, to bend the cost curve. It is the future. It's either that or cuts of 1%, 2%, 1%. And so folks need to learn to evolve into that, or they're going to be hurting in about 5 years with Zarfix. It is a high-risk game, though.
I'm Susan Hink with Missouri Health Advocacy Alliance, and the technology in healthcare in recent years is amazing. It sounds more like science fiction than reality, but I know it's real, and I know the effort is pretty much equal to moving a large mountain. But going farther, where are we with electronic communication with organizations outside of your own network, like nursing homes, independent pharmacies, labs, home health agencies?
Good question. Mary, do you want to take that one?
Sure, I'd love to. I think that that is the mission of Missouri Health Connection, is to ensure that all caregivers, regardless of what kind of organization they're in, are incorporated into the system. And I think that the technology is really just an avenue to get there. It really does not limit anything, does not, it's unbiased, if you will. And we have to make sure that we roll it out in an unbiased fashion and build those networks where they may have been in silos, bring them together and bridge those silos. In many of the states that are along the same journey that we're embarking upon, they are looking at collaborative models to bring pharmacy benefit management systems together with Medicaid systems, so that it really is ubiquitous as far as what we can do. I come from a mission-oriented architecture for health information exchange, where the FQHCs were mostly the fundamental members of those organizations, and then it built up from there. And that, by taking that kind of an approach, you look at the most basic needs first and build it to that level, and then you can grow up, I think, the more sophisticated needs. So I think that's going to be the approach of Missouri Health Connection. That's our mission, is to ensure that it's equal across all of the systems, and we tie together healthcare in all its forms across the state.
Yeah, and Susan, I would just add that, as I said this morning, I do telemedicine in little rural towns all over Missouri every week, and so I'm very excited to finally, soon, hopefully, really have meaningful access to health information exchange. But I have a dear friend who's a prosecutor, and she keeps reminding me that our corrections facilities are mental health facilities in this state. And so sometimes we think, not entirely, but that they house a lot of folks who, really have mental health issues that end up in the prisons. And so, we have to think broadly about health care, because sometimes there are organizations that don't seem like they're healthcare organizations, but we really need to be able to connect to them.
Follow up on that, Karen, if I might. In Washington State, we had, as I said, the mission-oriented focus for our health information exchange, and we tied together the rescue missions in our community with the caregivers and the care management teams in the hospitals, so that they began to look at those patients that were having trouble finding health care, number one, having access, or having too much access in some ways. And so they partnered together to really help those patients and their clients manage their care better. And so really, healthcare is so broad. It's not just about a hospital or a physician office. It's done across almost every component of our lives, and we just need to open our minds to that. So.
Yeah, I just wanted, and I know your question was probably more to the technical aspect, how are we all going to talk to each other and so on and so forth. That concerns me much less today after being in this for a while than the change management process. In fact, I don't think the technical aspect is really going to be the issue. And in fact, much of it could probably be done today if we put our minds to it and actually break down barriers. The change management at the physician level, the change management at the patient level, and more importantly, the way that all of us, and Mercy is guilty, as SSM is guilty, as is the University of Missouri is guilty of holding on to our own little fiefdoms and not opening up to doing what's best for the patient. As an example, we did our telestroke. We didn't have enough neurologists to begin with in our system. We should have gone to the University of Missouri, who has a great deal of neurologists, and instead we went to Boston. Now that makes no sense whatsoever, but that's just a small example that we have to approach healthcare in a different fashion than we have in the past. We're changing the business model, we're changing the technical model. We need to change the social model that we put in place.
Yeah. Can I add on to that? I mean, I think the technology is not the issue anymore. We can do Skype. It's interesting you bring up prisons because we've been doing court out of our psych unit, HIPAA and court for 10 years. And it's really not the technology as much as it's just what do you want to do. I mean, only 3 out of 25 insurers around us would pay for e-visits. So that was the obstacle at first. Who's going to pay for it? Who's in network? I mean, we use the patient's data almost like they're civilians in a war zone, and we're all in our own little fiefdoms, and you can't get the record without it. And I think that's the beauty of HIEs. Let us start competing based on services. If you do a better job with cardiology than I do, let's let capitalism work, and let's let this thing start evolving. That scares a lot of folks because they've always had their silos and their walls, and they use the data as a way to build networks and pull people in rather than share and take care of these patients. So I think there's a little bit of a change there. But direct is there right now. It doesn't have as much use as you'd like to see. It's more of a push network. But Skype, we've done everything from put robots in nursing homes and let docs use them. All the technology is there to let folks communicate better. But again, the processes, as you said, and the who's getting paid, just follow the money, and that's what will tell you what will happen.
Okay. Question, Andrea?
I just wanted to ask, when you're evaluating the patient-centered medical homes and the new health homes, are you looking at patient satisfaction as one way to evaluate? Are you considering that? And then the sort of a related question is, how involved are the patients in the team? So they're not listed as a member of the team, and we were talking about this earlier today, but are they engaged? My sense is behavioral health is actually sometimes better at doing that in Missouri than maybe primary care, and I just wondered how you guys are working on that.
Sure. So the way the model is built, the patients should be giving feedback to the model. The way we built the team, the core team, is based on or the PMPM, I guess, is based on how we developed the core team as well, and how we developed the core team determined how we developed the PMPM. So those two things are integrated in terms of payment model. But yes, the patient should be involved in giving feedback, should be a part of the team. And we have considered, and I think in terms of the evaluation, are looking at patient satisfaction in the model too. There's some CAPS questions that we have built in, and we are looking at further guidance from CMS on. CMS is still determining some of its measures as well, so we're still waiting for some guidance from CMS on those things as well. But there are patient satisfaction surveys that the health homes are I think, already using.
Yeah, and I was just going to add a little bit. I think you raised the exact issue.
Chris, can you wait just a second?
And this is from the perspective of an organization that's attempting to implement the Medicaid health home. We have nurse managers who are contacting patients regularly to engage them in their own care. And so as a part of that's how they become a part of that team. And it goes way beyond the satisfaction surveys. I mean, they're probably contacting many of their panel of patients weekly, sometimes even more than that, depending on how much they use the ER that month. But it is an ongoing process, and sometimes patients are dragging their feet about having somebody contact them regularly about how much they smoke. I just saw our patient satisfaction surveys, and one of the comments in our satisfaction surveys was, stop asking me about stop asking me about smoking. But we ask them every single time, So I would say you have nailed the biggest challenge that we have in becoming partners with our patients and them improving their own health.
Andrea, in the ACO requirements from CMS, the 33 quality measures that determine whether or not you're paid any of the shared savings, should there be any, 7 of them are patient responses obtained through survey. But to your point, whether it makes any difference or not, we'll learn. But at least CMS has recognized that needs to be a portion of it.
That's the big difference between an ACO and the old HMOs, is the quality measures and the SAT. Sorry, the big difference in HMOs and ACOs, the quality measures and the SATs, and the outcomes and where the risk is residing. I think folks hear that and they'll start fearing it, but I think there is a big difference, and the measurements are key.
Yeah, and I think, this issue of sort of empanelment or, patients going wherever they can go, what we're starting to see and I'm starting to hear more of is patients saying, are you hooked up to my other doctors? I mean, we're starting to hear that from patients. Are you hooked up to this person? And so I think that's, we're going to get this groundswell of knowledge from the patients as they start to understand it's important that you're able to get records and that my other doctors are able to get records. We haven't said today, we probably ought to say that Missouri Health Connection is an opt-in health information organization, which is a little bit different than our surrounding states. So Missouri, as a state with lots of input that Andrea helped lead with the Consumer Council, made a determination to be an opt-in state. So patients will be educated about health information exchange and then opt into the system. So I just think we're talking about this. We ought to just mention that if people don't know that. So
we took the opposite tack. We're an opt-out HIE, and that is a big difference. And you're talking about, how easy is it to get people to sign in versus do they worry about it? I think the key is making it easy for folks to manage their status one way or another. I think both of them have advantages and disadvantages. But if you don't show it in the portal and have it opt out, we didn't see it being viable long-term with our physicians.